Utilising data in healthcare. Using data to help increase breastfeeding rates. How can it work? So what is predictive modelling? Predictive modelling is utilising data to identify patterns and recognise chances of particular outcomes occurring. It is becoming more and more popular in healthcare today, and in some ways it's becoming easier as data and patient records are becoming more computerised. However, we can now collect so much data it can be hard to know what is important. More about that later in the presentation. Using prediction for prevention. Bresnik identified 10 high-value cases of predictive modelling in healthcare. An example of the third one down, getting ahead of patient deterioration. In maternity, we now use a maternity early warning score chart to plot observations. It's not yet computerised, however the paper tool is easy to use and will flag up if a patient's observations begin to indicate sepsis is developing. We know this based on research and medical knowledge. The tool helps us identify if the observation trends are changing. This helps staff to react as quickly as possible to identify upcoming sepsis or deterioration before the symptoms clearly show this and the patient becomes really unwell. It is simple and no extra data is required, but it's really effective. This is one example of many prediction tools used in hospitals with the aim of being better prepared and enabling staff to act faster to ensure better outcomes. Predictive modelling in practice. At the forefront of news articles, and indeed everyone's minds at the moment, is the current outbreak of COVID-19. Leaders and health experts are using different approaches globally to best deal with the pandemic, and thus many predictive models have been developed and investigated. An example can be seen in the bottom graph from Science Mag Online. It shows 3 predictions for the pandemic from an amalgamation of sources, looking at the smallest number of predictive deaths through to the largest estimated number. Winans et al. Critically appraised published reports of predictive models for COVID-19, looking specifically at prognosis, detection of those at risk of being admitted to hospital, and diagnosis of infection. They found that predictive models were entering print and public domain very quickly, as needs must, and out of over 2.6 thousand titles screened, 31 predictive models were included. Of those studies, their review suggested there was poor reporting, a high risk of bias, and optimistic reported performance. This highlights both the significance of predictive modelling in trying to deal with a pandemic, how much value they can offer, but also how the urgent nature of this virus and its current threat to life means predictions may be rushed, poorly thought through, or more significance put onto them than is advisable. Therefore, it's important to recognise this and recognise the limitations of this. An example of this rush can be found on the Union website aimed at tackling health challenges affecting people living in poverty. It's fast-tracking accepted articles, publishing them in full on the website prior to their publication in any journal. Their aim is to create really easily available information to reduce the impact of COVID-19 on the most vulnerable, but is this at a cost? Brainard in 2020 from Science Mag is quoted as saying, "Statistical models of infectious diseases are vital for understanding where the COVID-19 pandemic is headed, but their predictive power can be limited by sparse data and rapidly changing circumstances." Missing data. To demonstrate the issues surrounding missing data, Stiglick et al. Completed a case study of risk prediction model for diabetes using data from civilian primary care and found that up to 90% of data was missing from some healthcare centres. And the impact of this missing data includes many wasted opportunities for predictive modelling. Roux et al. Looked at addressing the problem of missing data with longitudinal studies regarding the effects of trauma and agreed. They said having more types of data and a range of analysis would vastly increase the validity and reduce bias, creating a stronger piece of work. They said there are 2 types of data, ignorable missing data and non-ignorable missing data, and discussed using statistics to look at people with similar situations to fill the gaps of the missing data. This isn't as good as the real data, but a knowledge of missing data, its potential problems in predicting outcomes and how this may be addressed is really useful. Working smarter with data. According to Sugarloo, in 2020, the global predictive analytics market was valued at $2.9 billion in 2018. Jennifer Bresnik in 2016 discussed that bigger is not always better when working with data. She quotes research completed in America by Dr. Nguyen that found electronic data collected during an entire 30-day hospital stay was not more accurate at predicting readmission rates when compared with data collected in just the first 24 hours. By recognising this, significant amounts of time, energy and money can be saved, whilst retaining the accuracy of the predictive tool. Knowing this has implications on data collection within healthcare. It's more about ensuring the correct data is available to perform the analysis, rather than having every bit of data possible and working from there. It's about working smarter, not harder. So analysing the data itself is just as important as the data collection. The age-old data problem. Capturing the correct data can be challenging. Locally, maternity records are a mixture of handwritten and handheld notes. Some information is recorded on a database, some in some handheld notes. It's a crossover of two things. In Kettering, which is just a few miles down the road, women don't have handheld notes. All their notes are completed on Medway, which ironically is the same computer system used at Northampton, but these records can't be accessed across the two sites. Dalnord et al. Looked at linking databases on perinatal health and completed a review of literature and current practices in Europe. They looked at the broad range of data collection and found records range from really minimal to very comprehensive. This lack of continuity across the trust makes it so much more difficult to learn, share and predict. Back in 1995, the British Medical Journal published an article by Arabanda discussing the inadequacy of data collection in maternity care and how a centralised computerised system was necessary. He talked of a nationwide maternity data collection reform. Since then, there have been changes and vastly more data is collected and more inputted into databases. And the newest computer systems and databases do make it easier to analyse the local data inputted. However, we still seem to have the same problem of across-site data sharing, different maternity systems available and computer data collection systems. This has been an ongoing problem in maternity. In 2013, Bally et al. Conducted a survey of student nurse and midwives' experience of learning to use electronic health record systems and found they had little to no formal training and students had varied exposure to using the computer systems. Now, this isn't surprising as each trust seems to use very different systems. It can be argued there isn't much point investing a huge amount of time teaching this part of the job as they're so different and students may qualify and go on to work in a different trust. But it's still important to teach the value gained from good record keeping and data collection. Kirkin et al. In 2018 discussed the many purposes of midwifery documentation, including the opportunity to enhance care if it's completed correctly. They could find no previous research on midwifery documentation itself. This study highlights the lack of emphasis on the importance of data collection and analysis, and we still have a way to go in maternity. Investigating breastfeeding rates around the world. Why is it important? The NHS websites list the health benefits of breastfeeding, as seen on the left-hand side. There are a lot, both for mum and for baby. The World Health Organization state that globally, on average, infants who are not breastfed are 3 to 4 times more likely to die than those who had breast milk. And Stuve et al. In 2017 created an online calculator to estimate the impact of breastfeeding rates on population health and costs, and found a 5% increase in breastfeeding rates was associated with statistically significant differences in child infectious morbidity for US population. They said even a small increase in breastfeeding rates would greatly impact health costs for the first year of life in the US. With all these benefits, investigating why rates differ and how they can be improved is really important. Furyk et al. In 2019 conducted a survey looking at breastfeeding rates and programs in Europe and found a huge variation in breastfeeding rates ranging from 59% to 98%, and concluded that the importance of breastfeeding is key to population health and finances, so countries need to focus on education and health promotion. But they also need to focus on data capture so this can be monitored. They recommended renewed collaboration between countries and a central platform for exchanging information. Here is a brief look at reported breastfeeding rates from a few different countries around the world. So first of all, how accurate is this data that's been captured? The Centre for Disease Control and Prevention in America looked at breastfeeding rates by conducting telephone national immunisation surveys to cohorts of people, and then estimating a percentage of children that fit into the category of breastfed at birth, etc. This method of data collection allows the CDC to predict breastfeeding rates. However, it doesn't give an accurate picture, and you would need to go to individual states and their hospitals to get more accurate information on breastfeeding rates. In comparison, in the UK, data is collected and submitted monthly to local dashboards, and then these monthly figures are then sent to the Baby Friendly Initiative each year. This means data is likely to be much more accurate, but there is a delay in getting those yearly figures. I discussed that record keeping was not generic locally and the difficulties this poses on data analysis. With a global issue, multiply these difficulties manyfold. If data is able to be shared, then learning from other countries and practices could really help increase those breastfeeding rates, reduce those big differences, and improve health outcomes for many mothers and babies. In practice, UNICEF created the Baby Friendly Initiative in 1994 as part of a global partnership with the World Health Organization. In the UK, 91% of maternity units are working towards baby friendly accreditation, and breastfeeding rates are shown as improving. Let's take a brief look into why breastfeeding rates can vary so much in different parts of the world. By looking into the maternity care provided in each country, you can gain a little insight into why breastfeeding rates differ. A simple way to investigate this is to look at maternity leave available. I've put a chart on the left-hand side of the screen. America has a notoriously lacking postnatal care system, and women routinely go back to work between 2 to 6 weeks following the birth of their baby. Being back at work would definitely impact breastfeeding rates. Compare this with the UK's up to 1 year of paid maternity leave, and you can see there is a slight increase in the number of babies feeding at 6 months in comparison, but it's not as much as you would expect. As you can see from the diagram above, Canada has the largest amount of paid maternity leave. However, their breastfeeding rates are lower than countries with lower leave. Daniel, in 2020, discussed that in poorer countries, such as Nepal and Sri Lanka, they have a 99% breastfeeding initiation rate, compared with the 89% in Canada. She discussed this is partly due to lack of access to formula in poorer countries, but they also highlighted that countries with better breastfeeding rates also have cultures and policies that support breastfeeding. The World Health Organization report that nearly all babies born in Sri Lanka are in baby-friendly hospitals, where standards are aimed at promoting breastfeeding and close bonds between mum and babies. Only 2% of hospitals in Canada have UNICEF baby-friendly status currently. So what can we do? Shotis in 2019 looked into the effectiveness of interventions at increasing breastfeeding in the UK and determined features of successful interventions, and advised that providing targeted, personalised support to new mums looking at local needs was the best way forward. Peregrino et al. In 2018 agreed. They found that neighbourhood context was really important in breastfeeding rates. In more deprived areas, breastfeeding rates were up to 40% lower and recommended area-based approaches to tackle this inequality. Evan et al. In 2004 carried out a similar study using a breastfeeding attrition prediction tool, but also looked at maternal age, marital status, education level, etc. They found the higher the education level, the higher the chance of successful breastfeeding. Ryan et al. In 2002 found the same. Having a close relative or friend breastfeeding also increases the likelihood of breastfeeding. This research was carried out in America, where there is a different postnatal care system. Much less maternity leave is available, and women may have to return to work much sooner, especially in the lower income and education brackets. This might be a factor in these results here. Havens and Wines in 2019 tried screening mothers at risk of weaning early and referring people to lactation support specialists. Using a breastfeeding attrition prediction tool, they identified women at high risk not to meet their breastfeeding goals and gave them extra support. This very small study identified that they were able to increase breastfeeding rates. A very positive outcome, proving that individualised care and the use of predictive tools can really help. It would be useful to see this now scaled up to a much larger study. Breastfeeding nutrition tools have been used in several studies, and they have been proven as useful aid to tailoring care to suit the needs of women locally and individually. Breastfeeding is a global issue. Information is shared and learned around the world, made much easier today thanks to the internet. The importance of learning what works together, whilst recognising the different challenges each area has, will enable healthcare providers to give the best maternity care to women and their babies. Exploring the relationship between breastfeeding rates and oxytocin use in labour. I conducted a study to look at the relationship between breastfeeding rates and the use of IV oxytocin in labour. In our local trust, we have approximately 30% of women having their labour induced, and I wanted to see if the use of the intravenous hormone syntocinon had an impact on the number of women breastfeeding their baby by the time they were discharged from midwife care at around 10 days postnatally. Studies have discussed the impact of the synthetic hormone used on breastfeeding. In 2015, Bridmer et al. Looked at the use of synthetic drugs such as oxytocin and epidural in labour and breastfeeding rates, and found that they significantly reduced the chance of a newborn feeding in the first hour after birth and breastfeeding overall. The limitations of the study included possible interactions between other drugs and oxytocin, and they weren't looked into. Also, a literature review by Cadwell and Bridmer in 2017 discovered most research on breastfeeding demonstrated the use of synthetic oxytocin had a negative impact on feeding, and no study could demonstrate a positive relationship between oxytocin and breastfeeding. This evidence is hard to unpick, as there are so many factors affecting breastfeeding, including a person's own experiences, preferences, overall health. There are so many variables involved here. But my aim was to see if I could find a link between this one variable, the use of syntocinon in labour, and breastfeeding rates. My alternative hypothesis was that there would be a reduction in breastfeeding rates on discharge from the community midwife where oxytocin had been used to induce or augment labour, resulting in a vaginal birth. Data was collected from the local trust maternity database and looked at births from November to December 2019. The data includes all women who had a vaginal birth, including normal, ventouse or forceps deliveries, but discounted women who had a caesarean. I didn't include women who had a caesarean in the figures, as Zindaro et al. In 2010 and Jody et al. In 2013 both found that women who had C-sections were less likely to breastfeed than women who had a vaginal birth, and didn't want this to impact the results. The nerdy bit. 351 women met the inclusion criteria of having a vaginal birth between November and December in 2019. 111 had IV oxytocin and 240 didn't. As the numbers in each group were not equal, their proportions were analysed using chi-squared. You can see my workings out on the screen. Chi-squared statistic is also known as the goodness of fit statistic and is commonly used for testing relationships between categorical variables. The null hypothesis of the chi-squared test is that there is no relationship between the two variables, that they are independent, and it's just investigating if that's right or not. The p-value is calculated to determine if the evidence gained was strong enough to draw conclusions. The p-value for this analysis was set at 0.05. Following the analysis shown above, the p-value was found to be 0.034, therefore the null hypothesis was rejected and the alternative hypothesis accepted. The results can be easily seen in this graph. You can see the proportion of women breastfeeding who had no oxytocin is higher than the women breastfeeding who did have oxytocin. Things that I need to consider here are the limitations of the study. Due to how the database works, I was unable to differentiate women who had preterm births or other drugs during labour, and both these factors will have some impact on feeding rates. Other factors such as previous births and previous feeding experience will also impact the feeding rates. The survey was done over a 2-month period, and a more longitudinal investigation may be able to add more insight and give more reliable data. Moving forwards, the next steps. The aim is to use knowledge gained here to inform and change practice to benefit all service users and decrease the gap between breastfeeding rates of those who need oxytocin in labour and those who don't. An example of where to go next would be looking into offering antenatal teaching of hand expressing of milk to all pregnant women. This is currently offered to the high-risk pregnant diabetic women, as they are more likely to have babies needing assistance at birth. By offering this extra support to all expectant mums, the aim would be to increase knowledge, understanding, and emergency milk supply for women and their babies. Looking at data over a longer period of time may also help inform practice and ascertain if any interventions are having an impact on breastfeeding rates. It might be worth using an SPC chart to visualise the number of women breastfeeding on discharge from the community midwife over time, to better see if there are any trends or if the interventions implemented actually have an effect. Thank you. Any questions are welcomed. But in conclusion, overall there is a lot to learn and a lot to be gained from the correct use of data in healthcare. It can be a powerful tool, and we just need to know how best to manage, analyse and share the information that we have. Here are my references. Thank you.